Hello, my name is Andrew Gomes. I'm a PA student at Downstate.
Hi, my name is Dara. I am a first year physician assistant student at SUNY Downstate.
Together, we'll be presenting traumatic brain injury. The brain is divided into hemispheres, and hemispheres are divided into lobes. Firstly, we require the frontal lobe for reasoning, speech, movement, judgment, and behavior. Our temporal lobe is extremely important for memory and recognition of auditory stimuli and speech. The parietal lobe guides our perception of stimuli and recognition of stimuli and movement. The occipital lobe implements visual processing, and spinal thalamic tract directs our path for emergent pain and temperature. The left hemisphere is used for written and verbal communication, as we use our right hemisphere for art and expression. During our neurological trauma assessment, we will look for ABCs and four types of bleeding in our diagnostic tools. The epidural hemorrhages are the first sign of arterial bleeding that are caused by temporal bone fractures, and this is occurring between the skull and dura mater, and much of the blood supply will need revascularization to create a new path of blood flow. The subdural hemorrhages over here are coinciding with the existing brain injuries with venous and cranial plexuses. The CT scan shows concave crescent hemorrhage shape that extends across the cranial suture lines. Open head injuries and severe blunt trauma, force penetration, and puncture wounds are occurring between the dura mater and the arachnoid space. Subdural hemorrhages lead to contusions, hematomas, and cerebral edema. Oftentimes, these hemorrhages can worsen because of fetal brain injuries and also alcoholism. Thirdly, we'll speak about the subarachnoid hemorrhages, which occur with cerebral aneurysms. Cerebral aneurysms can take place at any time, even during your sleep. Aneurysms are just weak points in the artery that cause pain, putting pressure on the brain, which can rupture. And the arterial bleeds occur here between the arachnoid space and pia mater. There are different kinds of cerebral aneurysms, such as brain protrusions, contusions, fusiform enlargements, and mycotic infected emboli from endocarditis. Also, for our TBI presentation, we'll describe the arterious venous malformations and hemorrhagic strokes, which occur in 8 to 10% strokes, and between the intraparenchymal level. The traumatic brain injury. Traumatic brain injury stages occur from the sequelae of external forces injured after falls occurred or contusion in the intraparenchymal bleeding. Here's a picture from Netters. We see the carotid artery system and cerebral circulation comprised of the internal carotid arteries. The internal carotid artery provides blood supply to the brain. It's responsible for anterior, middle, and posterior cerebral circulation. The terminal branch of the basilar artery supplies the inferior aspect of the cerebellum, as the basilar artery supplies numerous branches to the brainstem, and the superior aspect of the cerebellum, formed by the vertebral artery branching from the subclavian artery. Finally, the anterior communicating arteries are formed with the basilar and posterior cerebral arteries, forming the cerebral arterial circle, known as the circle of Willis, that's affected most during a TBI. What nerves are damaged? Axonal injury, of course, with loss of consciousness and risk of increased intracranial pressure. Concussions that are temporary, complementary of retrograde versus anterograde amnesia, which can alter mental status, and our ventricles, which provide cushioning for the brain, as the coracoid plexus produces almost 450 cc's of CSF each day. Are there nerve impingements? Of course. Clinical signs of fixed and dilated pupils on the ipsilateral with motor deficit on the contralateral side when basal ganglia, pons, and cerebellum are damaged. Fatal risks lead to brain injuries, herniation, intracranial pressure, palpal edema, which is a hallmark sign, paralysis, paresthesia, feeling of pins and needles, and long-term decline in cognitive ability over people the age of 60 years old. My partner Dara will now take it over to discuss the case study.
Thank you, Andrew. So now we are going to consider a realistic clinical scenario. So there is a 34 years old South Asian patient who is a man, presented in the emergency department with bicycle helmet damage from road collision. He is suffering from a headache, lower back and shoulder pain, fractures to the L4 vertebrae body, soft tissue injuries to the left knee and shoulder, and some memory loss. So the very first immediate line of action is for us to use the Glasgow Coma Scale, which is out of 15, and it is divided into 3 subsections. The first is an eye-opening response. Second is the best verbal response. The third is the best motor response. And patients with a score of 8 or less are considered to have suffered a severe head injury, which could be highly fatal. And in our clinical scenario, the patient only suffered mild to moderate head injury, and he scored a 13 out of 15, which isn't fatal. The second line of action is to perform neuroimaging, CT scans, and X-rays. And by doing so, we were able to rule out skull fractures, subdural hematomas, diffuse injuries, because there was no indication of intracranial bleeding. For the clinical manifestation, there is going to be a need for physician intervention, but however, there is no need for surgical intervention because, as stated earlier, the patient only suffered a mild to moderate head injury. The second is for us to refer the patient to physical therapy. The patient will definitely need physical therapy, cognitive therapy, speech therapy, and pain management as well. A follow-up surgery will not be needed because there was no severe head injury suffered. And it is important for me to note that a loss of consciousness for any amount of time raises suspicion for a TBI. Therefore, it is a must for us to conduct the necessary steps of action. The nerves that will be affected will be the C5 and C6 nerves, which will affect the upper extremities of the body. But however, most importantly, the L4 nerve will be affected, and the L4 nerve will have the zygotic nerve. And the zygotic nerve is, a damage to the zygotic nerve will cause lower back pain or tingling and numbness. As Andrew stated earlier, an epidural hematoma is fatal because it damages the middle meningeal artery. And if you bring your attention very closely to the image here, we have the pterion, which is the weakest part of the skull. And so unfortunately, the middle meningeal artery runs along the same direction as the pterion. So therefore, an epidural hematoma could be highly fatal because there will be arterial bleed. A subdural hematoma, the area affected, there will be damage in the space between the meningeal layer of the dura and the arachnoid, and it occurs in about 30% of patients who suffered a TBI. Traumatic brain injury is unfortunately the leading cause of death and admissions to hospitals among bicycle-related injuries. And about 51% of cyclists did not wear a helmet, causing them to become victims. So these are a few avoiding risk and prevention. First is to wear a helmet, be safe. Second, always wear a seatbelt and live a safe lifestyle. Thank you very much for your time. Bye.